Our final speaker is called Keaton Jones, who has just completed his general surgery training in Oxford and is about to start his HPB and liver transplant fellowship at the Royal Free in London. Keaton is going to speak to us about how to shape the future of robotic HPB surgery training. Thank you, Keaton.
Thanks. So I'm acutely aware that it's 5 o'clock and I'm the last speaker of the day. So I've watched all these fantastic presentations and slowly seen what I need to take out of my presentation to not repeat things. So what I'm going to discuss is focused much more significantly on UK-based residency, so registrar training. So not thinking about fellowships, post-residency training. I'm thinking what's going to happen in the next 5 to 10 years as robotic HPB surgery continues to increase in its prevalence. And the big elephant in the room is us as registrars who are going from a situation where we are competent at an open Whipples at ST8, and then you spend 9 hours sitting between the legs holding a sucker, and that you can't sugarcoat that. And so we need to think, I think we need to think carefully now about how the HPB community can start to address some of the training concerns going forward in order to improve the experience of trainees. So I'll talk a little bit about how it's been a disruptive technology for trainees, whether or not there's any opportunity for the postgraduate surgical training curriculum in the UK to address any of these concerns, a case study about how we've tried to address it in Oxford, and then opportunities rather than just spending 15 minutes moaning. So disruptive innovation, clearly, if you were the CEO of Blockbuster or a London black cab firm, you wouldn't have been happy with some of these innovations. And similarly, that open Whipples competent ST8 wasn't happy when all of a sudden the rug gets pulled from under your feet and you're sitting between the legs again. And similarly, in HPB, there's been a different evolution because in colorectal, my colleagues at the time, ST8, perfectly comfortable doing a laparoscopic anterior resection, their transition into a robotic anterior resection was pretty seamless. Going from an open to a robotic Whipples was a completely different story. And there are some innovations that you are happy with, unless you really like hoovering. I really like my robot hoover. However, when it comes to operating, I think one of the beauties of being a HPB trainee was those complex long operations, the dynamic and the discourse over the operating table with your mentors, and all of a sudden that was lost. And it wasn't until I started sitting at the console I understood why that was. And I know Adam talked this morning about that flow, when you sort of get in the zone and you start to forget about the fact that there are other people in the room. You can obviously talk to the other person on the other console. And it's not until I realized when I can hear this sort of screaming and my arm one is trapping the assistant on the bedside, that I realized there are other people in the room and you need to be aware of what you're doing. So robotic HPB surgery, I think this room is a select audience. So we have early adopters, we have innovators, but there is still the bulk in the UK of the early majority and late majority yet to come. But it's likely in the next 5 to 10 years that this will change and that arrow will shift and there'll be late majority and laggards. As trainees, we need to recognise that that is something that will evolve and happen. We won't have any control over that. That is something that we need to try and accommodate during that transition phase, but we're not going to overcome it. So in the UK, for those of you who are unaware, we have a structured training programme where you do some junior residency and then your surgical training is 6 years of structured training, followed by with or without a fellowship. And at the moment, what happens is, for the robotic HPB training, we went from this situation where we have expert consultant HPB surgeons disseminating their knowledge down to more junior trainees. And overnight, that was flipped. And so we had a situation where instead of having the dissemination of expert skills down to the juniors, the consultants overnight, who were extremely competent at the open procedure, suddenly they knew exactly what they wanted to do, but were using a completely new technique, unless you were one of the handful of surgeons who were doing it laparoscopically. And so as a trainee, you're suddenly going, well, I've been completely displaced. I'm no longer learning. I know we've heard a lot about how much you can gain from being at the bedside, and that's fantastic and important. But equally, if you are a senior HPB trainee currently, and you're in a unit where half of the cases have gone to robotic, that does create some anxiety. And what you want to know is how long is that going to take in your unit? And we've heard a lot about learning curves and how long that's going to take. But in the UK, there's a heterogeneous case mix in terms of units and volume. Our Oxford volume is about middle in the UK. And so when you think about how long your unit and your surgeons are going to take to become masters and then start disseminating that knowledge down so that you as trainees can start benefiting from it, depends on things like unit volume, surgeon volume, how much open experience that consultant had before embarking on the robot journey, console access, whether or not there is a second console for training, case mix. That was a significant interesting thing that happened in Oxford, is that as soon as robot Whipples came along, there was a case selection bias. And so the open ones with the post-neoadjuvant vein resection and the simple cases were going forward for the robot. And so those ST4 and 5 trainees who would normally cut their teeth on the simple Whipples were missing out on those experiences. And then existing experience and external pressures, thinking about trusts, timelines, theatre utilisation. And so really the training impact has been, from my experience, and this isn't based on data, this is my opinion, and I'm speaking liberally on behalf of trainees in this respect, there were fewer open lists. We had 4 open lists a week, we went down to 3. So that was a reduction of a quarter overnight in the open training opportunities. We recognised early on that industry, for the right reasons, were gatekeeping access to the training courses. We in Oxford have only 3 consoles, so 1 console on any given day available for training. The case selection, as I've already discussed, in terms of the easy or more difficult cases, and then regional parity. So the speed at which each region in the UK has taken up and progressed with their robotic surgery has been drastically different across the UK. And so largely that's a postcode lottery in terms of your training. If you were fortunate to be in a place that was an early pioneer, your consultants have become expert earlier, you're going to benefit. And similarly, if you're in a centre which hasn't had that opportunity, you're going to be at a disadvantage. There's an evolving and dynamic picture. And what I mean by that is, as these things are changing, writing these slides for this presentation, I did at a trainees conference 6 months ago. It's amazing how quickly you have to change things, change numbers, because the picture is changing so quickly with the uptake in that steep curve of UK centres. So what do we need in UK training? Well, we're notoriously bad in the UK at workforce planning. We have no idea how many robotic surgeons will be required. It's unlikely every unit will require every surgeon to be robotically competent, so we don't know how many we'll need, and therefore, how realistic, feasible is it to say every UK trainee should even have the opportunity to train robotically within a postgraduate curriculum system? What do the public expect from trainees coming out of a publicly funded training system? What should trainees be feasibly offered, but what can trusts afford to and feasibly provide? And finally, what is the role of the GMC? The GMC is the statutory regulator for our postgraduate training, and so they have ultimate oversight over what should be and can be delivered via our curricula. And the UK surgical curriculum, obviously, some of us have just been through our CCTs, and we will be acutely aware, it's quite surprising to CCT in the UK, you don't have to be able to independently perform major liver resection or pancreatic resection, just a cholecystectomy, and your minimum caseload is 35 major HPB cases. So if you look closely at our curriculum document, which changed in 2021, so this is the current model, updated in 2023, this is it for qualifying as a consultant HPB surgeon in the UK. And as I said, for the major HPB cases, well, it's level 3. And if you notice, if you control and search for the word robot in the curriculum document, it doesn't exist. And the reason that's important is because as a trainee, sometimes trainees complain about having to satisfy certain requirements in a curriculum, but equally it's really important to be aware that without those things being in there, we don't have the stick to prod for the funding and the access to courses and training provided by HEE or Health Education England. So just very briefly on curriculum design from the GMC, in response to the new standards for postgraduate curricula, which were implemented and prompted the change in our curriculum in 2021, they have to evolve to meet current and future advances and strategic workforce needs. So that would suggest that our curriculum needs to adapt in response to the change in what is happening strategically around the UK. However, in order to do that, the training needs to be offered in every deanery and across 4 nations. And so currently, if anyone attempted to bring about a change in our curriculum to introduce robotics, it would be completely unfeasible and the GMC would reject it. So I'm just going to move briefly on. What can we do to solve the problem? We're not going to bring about a change currently in the curriculum in order to address these issues. So the problem has to be tackled and solved bespoke and at a regional level. I would suggest that it needs to meet the needs of the service, but also the needs of the trainee. As we've already heard, we need to ensure that the expectations of trainees are managed. And we need to think carefully about workforce planning. We're very fortunate in Oxford to have a surgical care practitioner who's taken over the role of bedside assisting, freeing up the surgical trainees to do more console work. And as a HPB community, I think before we wait for colleges, JCST, the GMC to bring about a change, it's an opportunity to take an ownership over the problem and start to solve it ourselves. As an example, we offered a course, Liverpool offered a better course then later on with anastomoses for opportunity for trainees across the country to go to a regional training programme and start developing their skills. In Oxford, one simple thing we did, we used to have 4 open lists for trainees. We suddenly lost an open list, a robot list. Instead of having 4 trainees, we retained 3 trainees, which means those 3 trainees get equitable access to open lists, but the additional senior trainee then gets their access to the robot list. And so for me, that meant in Oxford, as an example, as a senior trainee, in the final year of my training, I followed that Fellows Intuitive Training course pathway. Prior to the start of 2024, I did my wet and dry lab training, did my first console case in January of 2024, and then I CCT'd 10 days ago and had completed 32 console operations at that time. That was with a robot list once a week in the department, but at least half of those cases were Whipples, and I didn't get involved in any of the Whipples cases. It was only the level 2 procedures. And so by the end of an ST8 year, so this is not fellowship, this is within the training, I'd done my level 1 procedures and then did enough level 2 procedures and a total console cases in order to achieve the certificate of equivalence, that's the one, yeah. So, and then this goes to show, I think, what is currently happening is 2025, I CCT'd with 112 major resections as the primary surgeon and 18 as a robotic. And I think that's likely, that ratio for whoever's giving this presentation in 2 or 3 years' time is likely to change. That might be heading towards 50-50. Opportunities as trainees, access to videos. We never really video our open operating, go back, reflect on our moves and so on and so forth. And so it's a really fantastic opportunity to use things like the OSAT scores to go back and assess our skills and how we develop. This is my second distal pancreatectomy using the intuitive data from the app. And you can see the spread of swapping between my supervisor or my mentor and myself. And then this was February 2025, and you can guess what part of the distal pancreatectomy that is when my supervisor took over, and then I was able to complete the rest of the procedure. And that's something that's really nice to see a progression using data. So what do trainees need? I think trainees basically need recognition that it's a difficult time during the transition. Nobody's going to completely solve the problem, but just recognizing those anxieties and put in some small mitigating steps in order to try and address them would make a huge difference. The college's external bodies definitely need to start to tackle some of this. And at some point, it does need to be adopted into the postgraduate curricula. We need clarity from the providers and supporters of funding for these courses on whether or not they will be funded going forward, because currently robot isn't in the curriculum, so it's not funded at all by Health Education England. And finally, mitigating its impact on training with reduced access to open lists. What I would like to that my experience in Oxford was completely and utterly dependent on my mentors and the theatre team who are here today. Everyone's sort of had that sinking feeling when the trainee goes on the console, it's 4:45 and you think, oh God, how long is he going to take? And so you really need to have supportive theatre staff and mentors. And I wouldn't have done it. Mike Silva, Zahir Zunwala, who are here, who helped and guide me through that training pathway at the end. Thank you.
Thank you, Keaton, for an excellent talk. Any questions from the audience?